I want Dr. Baechler to be give us all of her words of wisdom. For those of you who don't know me, I'm Deborah Bell. I'm the Director of Education for the Osher Center for Integrative Health here at UW. And we have a class with Dr. Baechler tomorrow night, and I really wanted to share her wisdom with the Department of Family Medicine. So I'll tell you a little bit about her from her bio, and then I'll add my personal part. So Dr. Courtney Jordan Baechler is a cardiologist specializing in prevention at Park Nicollet Heart and Vascular Clinic, part of Health Partners in Minneapolis. She has a master's in epidemiology and public health and is passionate about a healthy state of well-being, body, mind, and spirit for families and communities. Previous roles include medical director for health equity and health promotion at the University of Heart Foundation, assistant commissioner for the Minnesota Department of Health, and Vice President for the Courtney Jordan Institute for Health and Healing. He's a national leader in holistic medicine, health disparities, and prevention. Leadership roles include co-chair for the 2035 Minnesota Heart Disease Prevention and Stroke Committee, serving on the YMCA, the North General Board, and CVS Health National Equity Board. And Courtney and I worked together for many years at the Courtney Jordan Institute. She is, aside from just being an amazing person, she is a compassionate healer, incredibly wise, and caring about people's well-being for themselves, their families, and their community. And with that, I welcome you.
Thank you,
Dr. Jordan Baechler.
Thank you. Thank you. Well, thanks for having me. It's really fun to be here in Seattle. We're going to talk about some equity within the cardiovascular space, and I'm going to kind of start broadly. Then we're going to go into some Minnesota stats, and then we'll go into a little bit more about what we've done or what we've been trying to do from the solutions perspective. I do love interactions. I know that this is both on Zoom and here, but so please, if people have questions, feel free to stop me, and we'll definitely have to connect at the end as well. But I just sometimes I think, well, you really want to ask right in the moment that have something at the end. But so this is something I'm really passionate about. This is my family. My brother and sister and I are up on the top. We were all adopted. So I'm Persian and my sister's Hispanic. My brother is a little mixture of all sorts of European ethnicities. And my parents are down below here on the right side. So my dad is African American, grew up 10 blocks from where George Floyd was murdered, and my mom is Irish, and so we ran kind of a little mini Model UN, so to speak. And you can see the next generation, though this is very old, of the grandkids below. But I really wasn't aware of the disparities, period, that exist, but in healthcare until my third and fourth year at the University of Minnesota. So really, as you see here, especially from a cardiovascular perspective, what motivates me is this is my son, Will, though again, very outdated, and his grandpa. This was in Paris on his 70th birthday 6 years ago, actually, almost to this day. And that their trajectory is so different in terms of the outcomes, and particularly from a cardiovascular space. And as a practicing cardiologist, it's just mind blowing to me. And I specifically remember when my dad was in his 50s and he had passed the life expectancy as a Black man in Minneapolis, which we'll talk about more. So again, just to go again, we're going to get into specifically the cardiovascular space, but to just take us a little bit big picture as it relates to 12 of the 15 leading causes of death. African Americans have higher death rates. You can see Black and our American Indian populations have higher age-specific death rates than whites from birth through retirement years. Hispanics have higher death rates than whites for diabetes, high blood pressure, liver disease, and homicide. And minorities in general get sick younger, have more severe illness, and die sooner than our white population. And you can see here that this is nothing new, right? There's unfortunately a huge historical perspective that since the very beginning of time, with our first settlers, these disparities have existed. I think everyone here knows about this is the syphilis trials where we actually had a cure, but did not use it in Black men to see what happened if you didn't give them the cure. And then even as late as the 1990s, in a prestigious academic setting, they did a study where they withheld treatment in young Black children, and that showed that there was a genetic etiology of aggressive behavior. And then the IOM talked about some unequal treatment back in 2002, that you were less likely to get appropriate care as it related to bypass surgery and cardiac meds. And then in 2004, again, some older data now, but basically everything that we do in cardiology, from angioplasty to lytics to bypass, 21 out of 23 of the time shows that African Americans were less likely to get what they needed and ultimately to get bypass surgery in these situations. So I really appreciate this slide, which is very old, it's from 1996, but basically explains that race itself is really a systemic construct, and that there really is no biologic basis for that we, as we've done more and more with genetic analysis, we're 99% the same, despite these outcomes that we have. And so what do we do with that? And again, I think I'll help you get to where at least I have with all of this. So getting more specific with heart disease, you can see again, highest rates of heart disease in our country, in our Black population, 2 to 3 times more likely to die from heart disease. We've been seeing overall our outcomes improve for our white population, but not the same for our Black population. And in our Medicare population, you're 42% less likely to get a defibrillator if you have an ejection fraction less than 35%, or whatever the case might be if you're Black compared to our white population. And so now kind of looking at some of the risk factors, so to speak, you can see here that unfortunately the people that do the worst in the population, right, are Black women. So as it relates to high blood pressure, which we know is a risk factor for developing heart disease, you can see ultimately that, again, our Black female population has the highest prevalence rates of that. When we look at hospitalization rates in diabetics, between our Black and white population, more likely to be hospitalized, less likely to have their blood sugar controlled, less likely to have their cholesterol controlled, and less likely to have their blood pressure. So again, like, one has to wonder what of this has to do with genetics, and what is, again, sort of the approach to construct. When we look again at risk of having a cardiovascular event with diabetes, you can see that our female population, again, so the most challenging in both Black women, any cardiovascular event, heart failure, heart disease, heart attack, or death, all more likely in our female population than our male population, and we can mirror on that with women. So in summary, Black and Hispanic women have the highest rates of obesity. Black and Hispanic women have the highest rates of diabetes and high blood pressure. And women in our Black population are less likely, if they're seen in the emergency room, to actually presenting with chest pain, to actually get any angiogram. So pretty bad stats. If we look at some of the other things in the cardiovascular space, so as it relates to atrial fibrillation, it's interesting, and again, some of this could be just what the data is, but there's actually lower rates of atrial fibrillation in our Black and Hispanic population compared to our white population, but they're less likely to be aware of their condition. They're less likely to be anticoagulated. And interesting, as we look at the DOAC, so warfarin versus Eliquis and Xarelto, if the people who are on Eliquis and Xarelto it's more likely to be even. So that also speaks, because we can warfarin, unfortunately, right, has a lot to do with insurance coverage. So lots of things playing in here. Transplant times, this has been achieved. We actually just published a paper on this a few months ago, but this has changed very little in terms of you're less likely to get a transplant. You can see here in 2014, 19.8 months on average for our Black population, as opposed to 12 months for our white population. 12.3 months for the Hispanic population, and again, a little bit of improvement in 2015, but still the disparity is success. So back in 2009, within the cardiovascular space, there was an effort to start to look more deeply at what can we do to change this, as the goal really being equitable care regardless of the race, ethnicity, sex, and age. And part of this, right, comes, and I know you guys all know this here in Seattle in particular, but our population is changing. So we can do, the right thing and try to get ahead of this, or we can just wait in that by 2050, the white population is really going to be in the minority compared to what it has been. I always think that this slide is really interesting because we tend to all think that we are not biased ourselves. So this was a paper that was done by Clyde Yancey that said, in general, do people receive different care based on race and ethnicity? And yes, everybody kind of agrees that in healthcare in general, this is the same. In cardiovascular care, yes. In your hospital or clinic, a little bit less. And then you personally, now no, basically, and so, and we all know that unfortunately we have these biases that develop really early, but what do we do to change them? I don't know about all of you, but I remember getting in trouble. I graduated from med school in 2004, so quite some time ago, but in 2002 at our county hospital, because I had switched and said, why do we have to say this is a 35-year-old white woman, this is a 36-year-old Black man, why does it matter? And this guy got all mad at me, and I'm like, okay, but we don't really have a lot of sickle cell patients here at our hospital, so where is it really relevant? But that's how we're taught, right? And it starts, we often describe the size of the person, the color of the person, the sex of the person. It's not really necessary. So here we go on door to balloon times. And again, you can see that gold standard is having that artery open up within 90 minutes, but you're less likely to have that happen if you're Black or Hispanic. So in Minnesota, we love to brag that we have had some of the best outcomes in cardiovascular space. We were number one up until about 2 years ago, since 1999. But it's really interesting as you kind of look beneath the hood a little bit more as to what's actually going on there. That's not true for everybody in Minnesota. So our Black population and our American Indian population do not do nearly as well as our white population. Again, we actually, as you'll see, have some of the highest disparities in the country, but when we aggregate these things, you don't see them quite as well. And interestingly, as things change over time, sorry, I think my pointer there it is, but anyway, doesn't really matter. As people live longer, they actually do better than our white population, but it takes in the very early age, just like we talked about earlier, those disparities are even bigger. And part of that gets to, again, some of these risk factors that develop earlier on that have nothing to do with genetics, as we talked about, but start to magnify earlier here. And you can see, again, as early as 35 to 44, there's a huge disparity where about 2.3 difference in terms of our ratio of our Black population to our white population of mortality rates. And when you look at these things, like I was mentioning, high blood pressure being one of them, big differences in who has access, who has control of these risk factors early on, where, again, our white population on average had about 74% in terms of blood pressure control, lower for our Black population at 57%, and lower for our American Indian population at 6%. And then we have an optimal vascular score. I'm sure you have something like that too, that has to do with blood sugar levels, being on a statin, blood pressure levels, and same thing. Again, when we look here, you're less likely to have that control if you are a racial or ethnic minority compared to our white population in Minnesota. Same thing with stroke. So again, no difference there. And we can all, again, like we talked about, understand that these are not our genetics causing these things, every single category, right? These are these social constructs that are really making a change or a difference here. So in 2014, the Department of Health in Minnesota started to look more closely at health equity. Dr. Ed Ellinger was Commissioner of Public Health at that time and put this together. Health equity is in a state where all persons, regardless of race, creed, income, sexual orientation, gender identification, age, or gender, have the opportunity to reach their full potential without the limits of structural barriers. And what I think, people talk about, well, as it relates to equity, we're just sort of boiling the ocean, but this kind of starts to get into So what is really driving these things, and how in healthcare do we start to look at changing this? So the zip code that you're born in really makes a difference in terms of your health outcomes. And so this is in Minneapolis, as Deb knows, that this is actually like a pretty small range. It's about on the furthest to the left, you can see that Medina, where the population on average lives to be almost 92, it's about 20 miles outside of Minneapolis. And then you can see the two lowest life expectancies right in Minneapolis, in Elliott Park, with an average of 67 years. So again, that is just a few miles from where George Floyd was murdered, where my dad was born, where our county hospital is. And then just across in St. Paul is the Rondo neighborhood with the lowest life expectancy at about 64.8. That is an area that you hear a lot historically because one of our main freeways went right through a very, at the time, prominent Black neighborhood, and basically still has not recovered, still lots of conversations about what should be done because it really ruined what was a thriving neighborhood. But so this really, really matters where we all grow up. So the statewide health assessment really was to kind of look into these things a little bit deeper and understand who is and who isn't having the opportunity to live a healthier life. Here's some high levels, and then we'll go down a little bit deeper. So in Minnesota, we found about 14% of our children live in poverty. 9% of Minnesotans between 18 and 64 have a disability. 1 in 5 families with children have a child with a special needs, only growing in our population. And our race and ethnicity diversity is continuing to increase with a high for us by 2035. We know our LGBTQ population suffers even more challenges, and we have an aging population like everybody else. So what can we do to change these outcomes? What are some of the key drivers? How do we link this a little bit closer with schools, with homes, with neighborhoods? You can see what we found. So education, it turns out like that not only is education the single best predictor, but the education of the mom is like the #1 life expectancy driver. So very interesting. And here you see graduation rates, right, in our Minnesota population. So on average, our white population is graduating at about 87% from high school, whereas our American Indian population is graduating at about 53%, and our Black population at about 65%. So as you'll see on some of the slides to come, these are key things that we have to link up with health, especially with how much healthcare costs, that we need to connect these a little bit better. So looking at diabetes outcomes, and if we compare not having a high school diploma compared to a college degree and who's doing well in terms of less likely to get diabetes, you can see there 11% versus 5.4%. Inadequate prenatal care. That was a friend of mine that's in town here that is a maternal fetal medicine doctor, and we talk about this all the time, right? All of us talk about no-show appointments, people not coming to care. But what's actually driving that, and then what's actually driving these long-term outcomes, which we'll also talk about how much your outcome in pregnancy ultimately influences your cardiovascular outcome. So without a high school diploma, only very few people getting what they need for prenatal care. So you're less likely to get that as opposed to having a high school diploma. And then the likelihood of smoking, again, also correlating with education, yes or no. So in terms of poverty levels, huge driver, right, of our outcomes. This, I think, is super interesting and sad. So you may know that Minnesota has the second largest population of Somali humans, and next to Somalia, and they are actually doing, so our foreign-born African population is doing better than our U.S.-born African population, which, again, having a Black U.S.-born father is very troubling, that this is the reality of what we see. And then again, working in an urban and living in an urban area versus a rural population in Minnesota also makes a difference in our opportunities for health and ultimately poverty. Home ownership, huge issue. I can tell you as former assistant commissioner, I spent a lot of time talking to folks about health in Minnesota, and that was the number one thing. Folks said, I'm not going to be able to get my medicines or come to appointments if I'm not confident about my ability to have a home long term and not knowing where I'm going to be next month. So in Minnesota, our white population, 77% of folks own a home, as opposed to about 25% of our Black population, which again, we know that that structural construct in terms of redlining and opportunity and bank loans and all sorts of things is a huge. So when we look at these things in aggregate, people were polled in terms of how much financial stress they have, a little bit, rarely, sometimes, or always, and then the correlation with cancer, COPD, arthritis, depression, diabetes, asthma, smoking, binge drinking, obesity. And so again, you can just see how these things are very, very, very connected, and how much one is driving the other. We live in Minnesota, land of the 10,000 lakes. It's a beautiful place, much like Washington in terms of beauty, different geography, but again, who gets to experience this is very different. And so again, in our own state, white Minnesotans are twice as likely to be using these parks as opposed to our populations of color. And again, a lot of that being that folks don't feel safe, they feel targeted by all sorts of people, but unfortunately, police was definitely something that came up. And so, how does that relate then to obesity levels, which again, we see higher populations of, or higher levels of obesity in our populations of color, but how much, again, does that make a difference if you don't feel safe and able to access what is free and possible? And you can see also how that relates to high school education, yes or no, income, and our LGBT. And we know, unfortunately, this reality of who is in our prison population dramatically being influenced by race and ethnicity in terms of not a one-to-one. So this is a little bit out of date now, but at that time, you can see our Black population was only about 5% of our Minnesota population, representing about 34% of who was in our prison system. So definitely some disparities there. So again, what we saw overall is huge opportunities to improve our education, employment, income, housing, transportation, paid leave, health insurance, and healthcare to ultimately then drive some of these outcomes. So we have, here's like the sort of rainbows of all this. We have been making some inroads to change some of this. So one of the things that we did because of the connection specifically with pregnancy is in Minnesota, we have a maternal mortality review committee where we review every death related to pregnancy, during pregnancy and then the year after. We added, I was the first cardiologist to sit on that committee, and what we did in part was we added racism, discrimination as actual contributing factors that as we went through to the care that people were experiencing to be able to actually identify that and then change that going forward. And a big part of that were some pioneers in this field, Rachel Hardiman being one of them, was really, really helpful to that. And you can see it as we review these medical records, right? This is the part that we play as providers and clinicians that in terms of the way that people were described and behaviors, it was often written in the medical record where you could actually see these various things that folks were facing. So, and part of that, as we talked about, is because really cardiovascular disease starts before pregnancy, but it's really a woman's first stress test, so to speak. And so we see things like gestational diabetes, gestational high blood pressure, preeclampsia and eclampsia, and women have up to 4- and 6-fold higher levels of developing cardiovascular disease later. That really wasn't something that was emphasized in my fellowship, and I think still is starting to just kind of slowly get out that folks need further screening afterwards, further risk reduction afterwards, or we just see those disparities really logarithmically get even bigger. So this was a paper we wrote, and I'm sorry that it's a little blurry here. But so again, this is Abbott Northwestern Hospital, where we have, again, massive disparities. And what we did is we looked at our own outcomes and who was most likely to get referred to anything afterwards. So if you were diagnosed with any of those conditions, high blood pressure, diabetes during pregnancy or preeclampsia, did you get referred to a primary doctor? Did you get referred to a nutritionist? Did you see a cardiologist? Anything. Didn't have to be, that anything was better than the other. And you were less likely to have gotten a referral if you were a woman of color. So again, we start to see how are these things happening. And what we did, I don't have a slide on it here, but this is something that I think is important. And so from that, I'm a huge believer that you shouldn't do research just to already show the numbers that we essentially know exist, but that we should do something to try and change that. So we did a pilot with a virtual only opportunity that we actually had as healthcare folks where you could get labs drawn at home, you could get labs drawn at work, all these things to make it easier for you to be able to get any type of medications or treatment that you needed for basic health conditions. And so we offered that over a 6-month trial period to these same women that we had identified that didn't get their risk reduced. We made sure that the women that were enrolling were, the people that were enrolling were only women of color. We actually didn't offer it to any white women until we filled the population sample size that we wanted with at least 90% women of color, because what we found in other studies that we did is if you're just looking for a number, the women who say yes are way more frequently white women. And then the study fills up, and again, you're in with another set of disparate outcomes. But it was such a hard study to just get off the ground because there was so little trust of who is this foundation reaching out to me, and what is this? Everything was free. We paid people for their time. But I'll tell you that the issue, it was ultimately successful, but to have something like that, then what do you do after 6 months? So it was, and I sort of just took these folks on as patients afterward. But it's a huge issue if it's a well-intentioned something, but that's just a pop-up for 6 months, which was one of the things that we really found out. So as it relates to academics, I think that this has been a huge piece for me because these were all things that were involved in my training. This was a group of med students put this together from Berkeley and talked about how much what we learned as we go through to become doctors is a little bit off or wrong. And one thing that's there is for a long time, there was discussion about there's a gene for high blood pressure and that it was more common in our Black population. That's completely false. At my time of study and during fellowship, we did this study at the University of Minnesota for a drug called Vidil. Anybody familiar with this? It's still on the heart failure guidelines. So 2 very prominent researchers, again at the University of Minnesota, did this study. It basically is hydralazine and Imdur. And the study came out that it didn't make a big difference, the combination of the 2 in this drug called Vidil. And so then afterwards, which is not how you do good research, they retrospectively went through the population to see if there was anything where they could show a positive outcome, and they found that in the Black population, there was a positive outcome. So as of today, still, it's a very expensive drug, and there is an indication if you're Black and you have heart failure that you should be on Vidil. And it's super controversial because, again, one, that's not how you do the study. 2, if you look in population in studies where we actually have any type of adequate number of people of color in the study, they in general do better because the medicine itself is so good compared to what we have in the community. And it's so equitable. So it's a huge challenge, but it's still there and just speaks to this. GFR, I hope you guys have it changed here, but it's just been in the last few years where we haven't had GFR rates Black versus or African American versus Caucasian, which again was wrong. And if you Google almost any cardiovascular risk calculator, it will ask you on there to put if somebody is black or white. How many of you have been in the room where you have somebody that is biracial? Or, I mean, it makes no sense in that I know that the guideline committee, they did that somewhat purposefully in the sense of the disparities that we have, saying, well, we should rate this higher. People should know that their risk of developing cardiovascular disease in the next 10 years is higher because of the statistics we have. Yes, but I think what's challenging in what we owe our patients is that it has nothing to do with the color of your skin. It has everything to do with our social construct. So people should not grow up thinking that this is inevitable to happen because it doesn't actually happen to be. And we as clinicians shouldn't be part of that incorrect information. So, sorry, this is a little bit hard slide to see, but so when we put this all together, what we understand is, there's so many issues, right? Communication, path of healing, clinician bias, historical trauma, our evidence-based medicine isn't all actually accurate. Time of clinical presentation, trust, insurance coverage, and access are all areas that we really have to work on to change this. And so back in the day when we were doing more work around equity before a lot of the current administration, there was a lot of papers being published by folks like the American Heart Association talking about like, what do we start to do to stop this revolving door that we're seeing that is just unfortunately not helping. And I know this one is also a little bit challenging, but they actually put together this paper that talks about actionable items and ways that we might be able to do this, looking specifically at linking up socioeconomic statuses. There's, I think, a lot of, I'm sure you guys are doing this in your Epic or whatever you use as an electronic medical record now to kind of help screen people and get those areas connected earlier. You can see on the bottom here that they talk about improving patient-provider communication, improving trust, engaging in the community much more, specifically in communities that have higher disparities, where we're really connecting the clinic to the community that way, where we have access to care. We were just talking about nights and weekends. I'm glad to hear that you guys have that here because we don't really do that in Minnesota unless it's an urgent care or an ER, which is unfortunate. Policy interventions that really look at the realities and changing some of these outcomes, and then finally looking at effective interventions to reduce the impact of early disadvantages is key. So supposedly this was where funding was going to go as of 23. Yes, you guys know that. Not exactly what we're seeing, but and specifically some of the evidence-based areas that they know would make a difference. Eliminating out-of-pocket expenses, decentralizing healthcare settings. Again, so changing where we have a lot of these places located, financial incentives for patients, navigation, including a lot of the liaisons that I think have been tried and true, inclusion of social determinants and risk stratification, culturally sensitive nurse-led education programs, and then leveraging social media and telemedicine. So I'm just going to highlight some of the things that we did. So we partnered up with iHeal in town, which is one of the longest Black newspapers in town. Again, recognizing that this was a group that started in the 70s, have long-standing trust in the community, does a lot better at communicating than we do in healthcare. And how do we bring those areas together? And what was nice was this specifically Insight News helped us form iHealth Together, came to us to say, how can we work together? Because we really think that this is an opportunity that there's still work going on with that group, but was one way to do that. We started the work that I was doing at the Minneapolis Heart Institute Foundation, just kind of, you can see here, we started a heart-to-heart education series, which I'll show you. We started a community clinic partnership with one of our federally qualified clinics. Huge issues there. I don't know if you guys have the same thing here in Seattle, but the way our federally qualified clinics work in Minnesota is they can only go to our county hospital for cardiology. And at the last clinic, as a reference point, we have about 100 cardiologists. That community hospital has about 8. So you can see just in terms of the ability to be seen, right? Like we're already setting these things up for failure. Because, and then what you're offered in terms of care, I rotated through both hospitals as a fellow. They're amazing. They actually have a combined fellowship now, but then what patients are actually able to access is completely different. And that is our norm now. So we started an opportunity where we did with the federally qualified clinic, we just at least provided pre-phone consults to help folks kind of figure out who should be going where, who should be getting things a little bit faster. But it's pretty sad that these are, again, systemic issues. We did some more health screening events and activities, but then like connecting people to the next level of care. And then a summer series, really letting the community guide the strategy, which I'll show you, and then promoting local businesses, specifically in these communities where we were really thoughtful about who we were ordering catering from, who we were, what type of supply chain things can we do as hospitals and whatnot to help leverage things that ultimately then economically help communities differently. So this was in the heart of COVID, and so these things were all virtual in the very beginning, but we just started having conversations, and the whole point was meant to be a kitchen conversation. We only interviewed folks of color and just had people talk about their experience within cardiovascular space, what was good, what was bad. And it was all sorts of places in town, so it wasn't dependent just on our group or anything like that, but just to really let people have more trust about, and this was things from aortic dissections to primary prevention and everything in between. We have a big intern program, and so we started getting our interns out in the community. This is North Minneapolis, which has the highest disparities that we see in Minneapolis, and we started joining Juneteenth events and having blood pressure screenings, doing ceremonial drumming, different things that, again, what we heard over and over and over was interest in discussions around mental health that ultimately led to other types of disease detection, things related to cardiovascular disease, which we know there's such a strong connection between mental health and the cardiovascular space. We started biking tours. This is through Deb's old neighborhood. And we would end with community barbecues, but just to get folks moving. But again, at least through my now, 20 plus years of cardiology practice, it's pretty rare that we're actually like out in the community, not just in our office, and starting to make the connections both ways. This was with our community clinic or our federally qualified clinic. We just started Monday walks where folks could come out and have conversations, ask questions. I don't know how many of you guys do the walk with the doc type of things, but the number of things that people will just say, hey, I get these palpitations. Do you think I should take them seriously? Would you see a doctor? Would you do anything? We started a men's group because we again see these disparities and the opportunity to have men start talking about the realities, the role that folks play in families, and just to be having different conversations that way. We worked out at a fresh market. So this is also on the north side here. And we had the fresh produce every Fridays for folks, and then we partnered that up with some recipes that would be made. And we got our local radio stations involved, and just to kind of get the word out. We wrote about it. So we wrote about it from the healthcare vantage point. This was an article that these were all in the local papers versus academic journals on purpose. And so there was one from the healthcare vantage point. There was one from Batala McFarland, who is again part of the Black newspaper I was talking about, recognizing that the people are the solution, not the problem. So how do we really do this from a different lens? And then a local yogi in town, Chance York, who we did a study with, again, because of the huge interest and emphasis on ideally mental health being a part of everything, and then also a real interest in natural, non-medication solutions whenever possible. We started a podcast because why not? Because everybody has a podcast. And so again, this is Patel and I, and we, and it's just been super fun. All sorts of people from, NFL Hall of Famers to many patients to just everything. One of our first trans aortic valve recipients over here who's in her 90s, and she was super fun to talk through. So, but again, just the goal being that this is real life for all of us, and how people are navigating how health was talked about or not talked about, right? A big piece of thing I always think it's interesting, if people don't know this, that when Medicare was, if we still have Medicare, but when it was first put through, it only covered half of the adult Black population because it was the only way that everybody would agree on things financially, and so whites were fully included and only half of the Black population. Like I talked about, community screenings wise, we partnered with the YMCA, and where we knew this would be a place that people could trust, and just came in, gave information, got some people connected with where they could then go afterwards if they needed more treatment. We also partnered, this was probably one of the most fun of the partnerships. So we, the Divine Nine, some of the Black fraternities or sororities across the country, we partnered with Edwards Life Science, which is one of the main TAVR, transaortic valve replacement industry folks, partners. So what's interesting here, and I think this is a huge opportunity if you can find these, is a lot of these things, as we know, come down to money, which is super depressing, but reality. So right now, 90% of who gets TAVRs are white men. And there's no difference in who gets aortic stenosis between men, women, and our race and ethnic populations. So Edwards has a huge interest to have people understand who is actually at risk for getting a narrowing of your aortic valve, and has put a lot of money and time into this. And so they have done some series with the Kappa Alpha Psi Black fraternity, and we went across the country and just did educational series. On Saturday mornings, folks could sign up for them, and we spent about 4 hours just talking about heart health. It was always, there was a crew of us from Minneapolis that always came. There was a cardiovascular surgeon from Louisiana who was a man of color, and there was always a local cardiologist, usually an interventional cardiologist, that's with the TAVRs, talking about things. That was also always a person of color, just to start having conversations. And these were very eye-opening. And once again, sort of what we couldn't do there was the screening portion. Now, AI has gotten so much better at handheld, basically echo devices. We're not quite there yet, but that will be the future where, you can just walk anybody through doing that and start to have a better idea. Challenges than what you do have it from an insurance perspective and things like that. We don't have that all worked out yet, but this was another piece that we took out of this, again, sort of our multifaceted approach was we partnered with Girls Taking Action, which is an amazing organization in town. And you can see just sort of, so they're high school girls. They do have a boys organization too, but we work mostly with the girls. And you can see here, I was born with the power to live a positive, purposeful, and productive life. I was born to bring hope to my community and world. And this is us at the legislature at the Capitol in St. Paul. And we created a program together in partnership with their co-founders around health. And so we basically took these young women to different places where health is actually created. And one of those places was the Capitol, because of laws and policies. They had to debate cereals. They did a little practical debate on why you would want a healthier cereal or like Lucky Charms. And it was fascinating to see the research and the folks kind of go to that. We went to United Healthcare, which is based in Minnesota, and to Optum Labs, and they got to see in real time, basically maps that Optum uses, which is kind of the data piece of United Healthcare to figure out different disease pockets. And they did this simulated one where they found out that this one particular apartment building was having a huge problem with asthma, and they weren't sure why, and it was such a weird situation. Well, there was a bus that was idling when it wasn't en route right outside this apartment building, and ultimately changed the bus routes, and the asthma rates went down. We went to the YMCA. They got to experience meditation and yoga. We went to various grocery stores. We went to the Minneapolis Heart Institute. They got to see some of our research labs to start to put together all the different ways that they can have careers in health and that they can influence health. And we had lots of conversations about how health is actually determined and the reality that it's not based on your race and ethnicity, and that these folks who were predominantly young women of color are not destined to a future of cardiovascular disease. So in conclusion, what we heard is trust is a huge issue, that you really need to co-create as you're creating anything, recognizing the past, and really looking for solutions together for the future. You have to really lead alongside the community and not in front of, which I think is what most of us are used to. Prevention is really the goal, and the number of industry sponsors that I had reach out, especially after George Floyd's murder in Minnesota, around we want to do things with amputations and this and that, because these disparities are everywhere. But it's really difficult to go out to a community and talk about defibrillators when there's no trust. People aren't ready to have a device put into their body that might go off inappropriately when folks are really trying to figure out what can we do to prevent this from ever starting, which is what we all want, right? And really community solutions that make this easier to address these risk factors in the aggregate are huge. Lots and lots of assets in the community. How do we do these things so that they make culturally relevant sense to folks? Who are we solving for? Who is actually being enrolled? How do we find mutual interests that benefit more than just us? And do we need to keep asking kind of the same data pieces, or can we move into the action mode? I think it's huge. And then this is, I think, my second to last slide. Really principles to stand by. I think the financial piece is really huge. And I don't know how many of you guys right here are involved in any type of clinical trials, but at an academic institution, the amount of direct and indirect that are taken off right away just to go to whatever ivory tower, is unbelievable. So I think that's really hard when you're trying to get a community partner, especially long-term, and so much of the money from whatever source is going internally. It's tough. So I think that's huge. So we, in any of the work that we did, we split 50-50, and it was a huge issue. I yelled at many times, but I think you kind of have to push for that. Like I said, leading in second position, physically showing up is a huge piece outside of your normal setting. When it comes to research, letting communities own the data is a big piece of things, and decide what's measured. Talks about data collection, science and arts, changing, transparency, and then credible messages. So this is just, I think Deb mentioned that I co-lead this 2035 plan, to kind of help prevent some of this stuff from happening. But I've been a part of this since 2007, and this is the first time you can just see some of our goals here, where you can see the community is really starting to lead these goals, and it's even the wording is different, where it used to say, blood pressure goals of blah blah blah, cholesterol goals of blah blah blah, and I think what we recognize is that's not really what the community is asking for. That's what we want for various reasons from a medical perspective, but the goals have to change, and then we can ultimately get to mutual goals after that. So I think we would all agree we can do better. But with that, I'd love to take any questions that you guys have. I know everybody is on the debate. Yeah. Yeah.
I'm Kim Collins. I'm one of the residency faculty. Thanks for talking to us. And one of the things I'm always interested in is residency teaching and provider teaching in general. You brought up sort of in the beginning, I think, like bias among providers, and maybe often we like to think that maybe we don't have bias in our visits, but that it's coming from somewhere, right? So there probably is some. And so I was just curious if any of the efforts or any thoughts about how to work on that kind of thing, and what educational efforts are that sharing data.
Yeah, I think it's a good question. I think what I'll tell you, I think doesn't work great is sort of the 1 hour deal that a lot of us have been exposed to, that you have like a 1 hour and you come in, somebody talk about like, this is how we're aware of it, and then it's done, versus like an ongoing piece. So I think creating a culture where people can sort of call it out if it's seen or ask questions, I think is huge. And then I personally, in patient interactions, and I work with residents and med students also, I will say, you know what, I'm going to get a black and white test because I know that these disparities exist. And I think rather than me say, I don't really think you need a strength test or this or this, I tend to over test in from a gender perspective, usually more so with women, and also in a racial minority population. And I will say that to the patient because we tend to minimize, as women, we tend to minimize our symptoms. As clinicians, we tend to minimize other people's symptoms. And so I want a test that takes that bias out for me. So that's one thing that I think has been helpful just to kind of have that, and I think as faculty that way, just to even talk about that with folks, that this is the challenge for all of us. I mean, I think unfortunately, right from birth on, our brain is constantly trying to like categorize things, and that's kind of what medicine is, right? It's algorithms, but like some of them in the way that we've been taught have been flawed and have to do with these biases. And there's so many others, right? Obesity and level of education and all these things that we're kind of deciding. Ultimately, oftentimes we decided who these people are before we walk through the door. So I think just being a little bit more honest about that. But I don't think, to what you're saying, I haven't seen anything that's been super amazing just straight from like a curriculum. So I think it's a hard thing to just learn. I think you'll ultimately have to experience, figure out how you're going to change to avoid that long term. But I do think that first line of the HPI is a real problem. Even like your trials with this, you're kind of like, oh, that's that person, But, yeah.
Are you doing any kind of longitudinal studies in conjunction with this? I remember the beginning of this, you were talking about what the average age of death was for various conditions. You're Black, you're smoking, you got high blood pressure, whatever. And what I'm wondering about is that comes from data that was collected at a specific time.
Yeah.
Are you collecting this data on an annual basis or every 5 years to see if your programs are making any difference?
So yes, the Department of Health in Minnesota is pretty robust that way, and these are constantly still being collected that way. The one thing that's challenging is now a lot of that data has gone to claims data, and it's so flawed. I don't know about you, I never code exactly based on who this person is. I just code on whatever they did that day. So I think that off the folks doing the data, that's going to be a little bit challenging, but the bottom line is, yes, it is being collected. So what I didn't say that, or I maybe said a little bit, but I think a huge piece of this is the access piece. So I think that the pilots and some of these projects are really, really helpful. But if they can't be sustained in their short term without ultimately people having easier access to get what they need, it's a real challenge. So I think how insurance does or doesn't change to better meet the needs of the population, it's gonna be huge. So that, but yes, the data is being collected.
I'm wondering about government policy, the law, et cetera. I remember 20 or 25 years ago, there was a piece of national legislation that had to do with the discrimination of non-white people to bank loans, especially for housing. And it was supposed to change things around. And I'm wondering if you ever saw any of that kind of an effect. If somebody was 20 years old in 1980, and applied for a loan and they got refused because they were black.
Yeah.
Even though the person that was matched, that was Caucasian, was granted a loan.
Yeah.
And if you can match those kind of data going forward.
Yeah, it's a good question. I don't have the answer to that, but it's really, I don't have the answer to that, but it would be great. And I think again, some of the stuff, like to the earlier conversation, we just have to kind of create now the equity piece and continue to collect the data that's already established, in the sense that we should all, like you're proposing, have the same access to get a bank loan, right? But not do a study just to show that it was disparate, if that makes sense. But yeah.
Fascinating. Thank you for sharing with us.
Yeah.
One of the challenges we have in primary care, and you've alluded to it, which is the holistic nature and the competing demands. And your focus has been on cardiovascular disease and risk calculators. Our patients come to us in primary care, though, not with a singular question of, doctor, can you keep me from dying of heart disease? They're concerned about their mental health, cancer, but maybe even worse, just paying their bills. And this notion of like someone being black is different than someone sitting in front of you with tears and saying, I can't afford my medicine. And then my trying to decide whether I need to order a cardiovascular exam when they can't even get their basic medicines. And so this gets to a larger societal question for someone in the American Heart Association. As the AHA and the American Cancer Society look at more research of identifying more and more risk and lowering blood pressures, the question is then, where's the money going to come from for these communities to build their school systems or to give the housing that's needed? And how do you balance this very specific notion of reducing cardiovascular disease with improving the health of communities?
Yeah, no, I completely agree. And I mean, again, I'm just perhaps making wrong assumptions, but I would assume everybody here in this room would essentially agree with that I would personally love to see less money going to anything cardiovascular based and more going to the schools. I think what I hope, though, collectively as clinical folks, that we continue to emphasize how these worlds are connected and how we do have a role in seeing that somehow, we stop hiring more cardiologists or whatever the case is, and emphasize that it needs to actually get to the schools. It needs to get to the nutrition in the schools. It needs to get the safety in the neighborhood. I get that it's not one or the other, but the data is such, right, that it's 90% of each dollar is going to healthcare versus any type of prevention. So, and I, to what you're saying, that reality is very true. In the moment, in the clinic space, there's only so much you can do, but we can't lose sight that we can't just keep band-aiding it here, because we are, and so how we become a part of that solution, I think. But I appreciate what you're saying. I don't expect you to only be focused on cardiovascular disease or anything like that. And we heard loud and clear, folks wanted mental health. But it turns out, which is a whole nother slide presentation, but 30% of cardiovascular risk is mental health. So it's totally related, and it's not just schizophrenia, it's social isolation, depression, anxiety, and all these things that lead to blood pressure being higher, lead to calcium scores being higher, and things that, so, I mean, I would be okay if we doubled down on resources that were available that way. Other questions?
Yeah, so I guess I'm old enough to say that the disparities that you highlighted sort of, like, it never changes, right? So there's just this frustration of like, why, there's just a systematic way of doing things in the country where you feel like nothing changes. And given your kind of lifelong work in this area, what advice do you have for us in the room? Like, what little steps can we take to just make progress in reducing disparities?
Well, I think, and that's at least in part why I would try to highlight all the different places that it's a problem, because, I mean, have you guys fixed all the race-based stuff at UW that is wrong in terms of GFR and pulmonary tests and things in echocardiograms and the risk calculators, like, because those are things that we can influence, right? I mean, so that's where, like, I think that wherever there is an opportunity for you to make a small change, you should. I don't know if you're part of the faculty here also, but like, I think that as folks in academics, we also have a role as we're teaching folks. Hey, we should start thinking about the way we describe people. When you present somebody to me, we should talk about this. We should talk about how to educate the information that we give, the educational materials we have. Because I bet if we went through some of your educational materials just like ours, they're flawed in what they're telling our patients. And that is biasing the folks coming in and the folks teaching and everything else. So I think that there's so much room to change that I do think there are things that all of us could do in this room. And even like, in terms of where you're seeing patients and what you're doing telemedicine wise, which different types of communities you're having, who you're bringing in terms of who's becoming your new family practice folks. What does that crew look like? Are you getting new physicians that reflect the community? What type of, so I think we have a lot of influence. And I do feel like things are starting to change. There's more and more, the face of medicine's changing. I think people's understanding that this isn't a genetic process. People, unfortunately, like pushing back and questioning a lot of the science that was flawed, so I think so much of that, that there's a problem there. And COVID was such a great example in terms of how the science and the communication was misleading there. My dad, as somebody who has a little bit of heart disease and is Black, was glued to CNN and did not leave his house because I swear he was like, well, COVID's gonna attack me different. COVID didn't attack Black people differently than white people. It was all these other things. We had a huge opportunity to explain that, but some of the disparities around education and what schools got back and stuff were maybe outcomes worse than that sometimes. And this was 5 years ago. So I just think like there's places where us as physicians need to speak loudly about what the reality is, help people live their fullest, healthiest life.
Thank you, Courtney. I think there's another meeting that's
Oh,
gonna
yeah, that's
start.
right.
So thank you so much
Yeah,
for being here.
You can see.